This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
All right, good morning everyone. My name's Jason Roberts. I'm from the University of Queensland and the Centre for Research Excellence, REDUCE, and it's a pleasure to be hosting you here today. I'd like to start off firstly with a welcome to country and acknowledge the traditional owners of the land on which we gather and acknowledge the leaders emerging, past and present. Well, firstly, I want to congratulate you on being here today. Firstly, finding the venue. It wasn't necessarily easy to find, but as you can see, it's quite a nice facility that we've got here and should allow us to have quite a nice day. All of the presentations are going to be recorded today, and there's a microphone here which is quite sensitive, so be careful about what you say in the audience because it may be recorded for posterity and be available to people on the internet. So, but it also makes it a lot easier, of course, for us to have discussions which others can benefit from in the future. So our Centre of Research Excellence is an NHMRC funded centre. It's fortunate enough to be in its final year, its 5th year, and we've been fortunate enough to run some really nice educational events, and this is just the latest of those. This topic of mycobacterial infections for me is something that I'm personally very interested in because it's not an area that I've done a lot of work in myself and is one that, certainly from a clinical perspective, that we're seeing a lot more questions that arise from both the treatment diagnostics and also epidemiological perspectives. And so we've tried to encapsulate a lot of that in today's program. And as part of that, I'd like to really acknowledge Andrew Burke, who's put a lot of the program together, and I think he's done a fantastic job, and we're very fortunate enough to have the speakers that we do. People that have come from all over the country, and including Joe Donovan, who's come from Vietnam as well. And so we've got a great faculty of presenters here, so I'm most grateful for their contribution that they'll give today. I'd also like to thank NCAS. NCAS is the National Centre for Antimicrobial Stewardship. They perform some magnificent work all throughout the country in trying to improve the way that antibiotics are used. Arjun, who's the centre manager, has provided a key role for us in helping organise this venue, so we're very grateful to them. And of course, I'd like to thank our sponsors. Some of them you'll see throughout the day. Please feel free to go and have a talk with them and ask them about their products and what they can, their services they provide. So BD, Cefad and MSD, we're very grateful for your support. Final comment I wanted to make before we get underway is that, as you'll note, that area out there where the registration desk was and where the morning tea will be, as well as the lunch, it's quite a small area. And I think it's probably worthwhile for us, once you've got your drink or your lunch at each of the breaks, to just move outside where you can get some fresh air and there's a bit more space. I think that'll just make for a slightly more pleasant experience for everyone. So what we'll do now is we'll move on with the program. Our first speaker today is Associate Professor Rachel Thompson. Rachel's from the Gallipoli Medical Research Foundation at Greenslopes Private Hospital in Queensland. She's a thoracic physician, and her interests include pulmonary non-tuberculous mycobacterial disease and environmental ecology of mycobacteria. So I'll welcome Rachel to the stage, who is with us for her last day before jet-setting overseas. And I hope this is the right one.
That's the right one, yes.
Perfect. Okay, welcome.
Okay. Thanks, Jason, and thanks, Andrew, for the invitation to speak today. So I've got two talks, quite a lot to cover in the epidemiology aspects, and perhaps a little less on the clinical trials. So if I go a bit over on this one, we'll make it up a bit later. So firstly, just a reminder, and I hope you can read that, where the NTM fit in the taxonomy. We've got the Mycobacterium tuberculosis complex, which most of you are very familiar with. But then we have now over 200 species of NTM that have been described, and the number seems to be growing every day. And traditionally these were just described according to whether or not they gave off pigment when exposed to light, and then also whether or not they grow either slowly or rapidly on solid media. And I'm not going to talk about all of these today, but we'll cover the most common. A fellow called George Comstock, who's an epidemiological expert, described epidemiology as the art of making sense of imperfect data, and that's certainly very true for NTM, because in most places NTM is not a notifiable disease, and part of the reason for that is because you need clinical criteria to define whether disease is present or not. And a lot of people have then looked at whether you can use microbiological data as a surrogate using laboratory notifications. But that also is fraught with some difficulty because not all laboratories speciate to the same extent or accuracy. Not all isolates are referred onto a reference laboratory, and not all reference laboratories are made alike. And then the issue of incidence versus prevalence is another difficult one. This is unlike TB, where you have a TB case that's treated and then no longer becomes a case. If you become an NTM case, you're often an NTM case for life. And how do you deal with this issue of relapse disease versus reinfection with new organisms, which occurs in about 40% of patients? So in order to define clinical disease, the ATS and IDSA came up with these criteria in 2007, which were slightly different to the ones from 1997, but really not very much. And you require clinical criteria of symptoms, appropriate radiology, and these are the microbiological criteria which require at least 2 positive sputum samples separately submitted, positive culture from at least 1 bronchial washing or lavage, or a biopsy with histopathological features of NTM in conjunction with a culture. And there have been a couple of intensive studies where they've compared the whole 3 criteria with just the microbiological criteria, and there's about a 90% concordance, and that's been done in 2 sites now. So micro criteria is pretty good. The other confusing factor is that with modern techniques, the taxonomy of many of these organisms is changing, and you can see the confusion created here around Mycobacterium abscessus. We've gone from being abscessus subspecies Chelone subspecies abscessus to abscessus maziliense balletii, then back to 2, now out to 3 subspecies. And what we thought originally, MAC being only avium and intracellulari, is now a lot more than that, and this chimera outbreak associated with the heticula units really brought attention to the importance of differentiating amongst the MAC subspecies. So all of those factors aside, there have been multiple reports all around the world that show that disease is increasing. On the left here we've got the report from the UK, dividing it up into subspecies, MAC being the most commonly increasing species, but a significant increase in abscessus. Over here we've got reports from Canada, and they've published quite widely in this area, again confirming declining rates of TB with increasing rates of NTM. In the US, they've looked at Medicare beneficiaries who are over 65 and shown a significant increase over that 10-year time frame, and then looking at big health insurance databases such as the Kaiser Permanente one in Hawaii, they were able to show some changes in speciation and disease incidence there. In our region, we've had some reports that have dated back quite a long way. Western Australia, there were some reports in the early days of increasing rates of Kansasii disease between 1962 and 82, and then again between 82 and 87. We've had a report from the Northern Territory showing an increase in prevalence of NTM disease from 2.7 to 4.7 per 100,000, with a yearly incidence of 2.1 per 100,000. There was a national survey of the reference laboratories in 2000 that was a very conservative estimate. It was based only on speciated isolates, and you had to meet the micro criteria, which demonstrated 1.8 cases per 100,000, which was probably very low or an underestimate. There's been one report from New Zealand that also shows a similar sort of incident, but according to ATS criteria, they only felt that 15% of their isolates were clinically significant. There's one small study from PNG looking at TB cases, 335 TB suspects, 225 were culture positive, but only 9 of those had NTM, which is quite low compared to the African studies where there's a lot more interest now with MDR and XDR-TB in providing accurate speciation, and a lot of the African studies are up around the 25 to 30% are actually NTM. And there's a small study from French Polynesia that looked also at TB suspects that showed a significant proportion of rapid-growing mycobacteria. And interestingly, there were 14 cases of abscessus in 2013 in that small country, and all of those patients had bronchoscopies, which raised the possibility of actually being a pseudo-outbreak. And so if you're interested in detailed epidemiology, there's a chapter within this very good textbook that David Griffith has put together that was only published last year that details all the changes in epidemiology in different countries around the world. In Queensland, we're very fortunate that the disease is still notifiable, and so we have quite accurate data dating back to when TB control was first introduced. And we drilled down into this data quite in a detailed way back in between 1999 and 2005 and looked at all of the clinical details of as many cases as we could to see what proportion were clinically significant and whether this was really a true increase. And certainly the rates per 100,000 have gone up significantly over that time period, approximately 17% rise per year. But the clinical significance of these does vary with the species, and it might be a bit difficult to read that, but when you look at this, the clinical notifications, approximately 40% of patients who grew intracellularly in sputum had significant disease. There were another 11% that were under evaluation, possibly had disease. Slightly less for AVIUM, higher for Kansasii, and then if we look down here at abscessus, only a quarter, which is interesting. This was in 2005, and perhaps that may have changed. We also looked at where was the increase? Was everybody getting more, or was it specific subgroups? And you can see here that the most increases were seen in females in the over 45, but particularly in this 60 to 74-year age group that had the statistically significant increase in disease, and a drop-off in the men, particularly in this middle age group here, which are your smoking, drinking, cavitary type disease. And if you look at the radiology of these patients, traditionally we've recognised this upper lobe fibrocavitary disease, very similar to the TB type presentation, and that was still the more common presentation in 1999, but in 2005 you can see this massive increase in the nodular bronchiectatic disease with this middle lobe bronchiectasis, lots of fine nodules progressing to quite severe bronchiectasis. We looked at the changes in species, and you can see that Mycobacterium intracellulare was the main pathogen associated with that increase. There were some increases in others, a little bit of Kansasii, but also this unspeciated slow growers, and that's where those extra 200 species come from, that a lot of these newer bugs are starting to appear in the laboratories, and a lot of them we don't know what they mean. We also saw an increase in rapid growers, particularly in the fortuitum and even more so in the abscessus group, which, as we know, is quite concerning. We then had another look at this data in the last few years from 2000 to 2016 and divided it up into the species. And you can see that the increase, the red line in the middle is the modelled incidence, and the blue dots are the actual incidents that we've seen, and it does vary from year to year, and it raises some interesting questions as to what's going on, why some years are have more than others, and whether some species are different to others in terms of their environment and their ability to cause disease. But there's certainly some fluctuations within that time period. We also looked then over the last 16 years at the age groups and the species, and just to point out on this graph here, you've still got this peak in intracellulare in older people, both males and females, but if you look at this dark line down here, this represents the abscessus cases in the 20 or even younger age groups, and I think a lot of that reflects the cystic fibrosis burden of abscessus disease, but similar findings to what we had before. So what's going on? Why is disease increasing? And people for years have been saying, oh, we're just diagnosing more, we're doing more CT scans, our labs are better at picking it up, we've got better mechanisms and a better healthcare system, so we're just diagnosing more cases. But I don't think that's really the full story, and we've been saying that for a long time now, and CT scans have been around for a long time, so that effect should really have gone away. We do have an ageing population, and I think the longer people live, the more likely they are to get this. We are better at looking after people, so our CF populations, our COPD populations are all living longer. But there is also this issue of environmental exposure and what's going on in the environment. If you look at worldwide variation of NTM, the species distribution is quite different in different countries. And you can see by this map here that the distribution of MAC, the blue is low prevalence through to the red being high prevalence of MAC, and then the bottom map here being abscessus. And there's different testing protocols and lab methods in those countries, but there's also a difference in the NTM in the environment according to the climate. In the US, they've plotted, there's two publications that have come out. This one here looks at SAT-scan clustering. These dark dots are areas of high prevalence down here in Florida and California, but also up here in the top east. The open circles are low prevalence areas up here in the cooler areas. And then they've reproduced this here, which again shows the states that have higher prevalence, and this is Hawaii that has quite a lot. In the first study in the US, they did look at some population and environmental factors that might predict the higher or the lower risk areas. And some of them looked at household income and soil levels and things, and they did show this mean daily potential evapotranspiration as being a significant factor. And that's defined as it's a measure of the atmosphere's ability to remove water from the surface through evaporation and transpiration to convert it to atmospheric water vapour. And the theory being that these mycobacteria form bioaerosols that can be inhaled in such an environment. We then went on to look in more detail at our geospatial mapping, and so because we have a notification system, we can look at where all of these patients live and look at the relative risk attributable to where they live. So you can correct for all the confounding things such as smoking and age and gender and all that. And we were able to show that some of these dense, darker areas where intracellulari was much more common, this risk factor was associated with where people live. And we also looked using at a lot of these geospatial databases that are available online at soil values and soil quality and water variables. And we could show that the intracellulari incidence in Queensland was associated with areas of shallow soil depth. Now, why would that be? Well, if you have a shallow soil depth, you don't get very good rooting of the vegetation and less uptake of soil nutrients. And so you have this rich topsoil that the mycobacteria can thrive in, but it also means that you don't have much water capacity or water availability for the crops. So farmers do this process of deep ripping to rip it up and improve the yields of the crops. And you can see this here shows what happens if you rip and if you have compacted soil. But that actual process of ripping, you can see, leads to aerosolization of dust, which may actually then lead to more being in the environment for people to inhale. We also then found different things with abscessus, and we found this hotspot of abscessus disease up here in North Queensland, which fits with a number of other studies that we've done looking at the prevalence of abscessus in cystic fibrosis. And Scott Bell, through the Queensland CF notifications, we looked at the incidence of NTM in people who lived north or south of the Tropic of Capricorn. And if you live up here and you've got CF, you've got a 25% chance of NTM. If you live down here, you've got a significantly lower, it's less than 8%, I think. And a lot of the abscessus was found around here, around Early Beach. And there have been some other studies that have looked at water quality and lagoons and things and as risk factors for abscessus. So we didn't find any of those correlations to come through, but it's nevertheless an interesting observation. We also found more Kansasii out here near Roma and Yulbar, and those areas use use artesian basin water for their town water supply. And interestingly, it sort of follows the oil and gas facilities that we have in this part of Queensland. And there have been a lot of reports internationally about Kansasii disease being associated with mining and heavy industry, and that may actually play a role there. We then looked in more detail at over the last the 2000 to 2016 at where the increases were, and the darker the blue areas, the greater the increase in NTM, and looked at all the different health service districts. And with that, we were trying to see whether those fluctuations in disease over that time period were in any way related to our periods of severe drought versus periods of heavy rain and flooding, cyclones, and those sort of major weather events. And we did find some things that we looked at rainfall using BOM data and found that 9 months after heavy rain, NTM went up in the northern areas. That was predominantly the slow growers, interestingly, but 6 months after heavy rain, the rapid growers actually went down up in North Queensland. But down in the western regions, where you'd expect it to be more the slow growers, intracellulari type dust-associated bugs, 3 months after an increase in rainfall, NTM incidence went down. We didn't find any differences or any associations between temperature and overall NTM incidence, but there were some little subtleties according to species. Abscessus decreased 6 months after heavy rain in the southeast, as it did up in the north. And in the north, if the temperature went up, abscessus went down. AVIUM decreased 4 months after rain in the west, which you might expect given that rain tends to settle dust. But there was no association between temperature and AVIUM. And we couldn't find any associations between intracellulari and rainfall or temperature in any of the regions. And there's a lot of issues with this sort of data because there's such a variable lag time between exposure to an organism and presenting with a positive sputum sample in the laboratory. So this sort of disease is very hard to correlate with environmental type factors. But nevertheless, some interesting observations. So we know that NTM are ubiquitous in the environment, and they've been found in a lot of different sources, including household, hospital water, bathrooms, potting soil, garden soil. And those sources have all been identified as infectious sources by matching the genotypic profile of the organisms from the clinical strains versus the environmental strains. And there are a number of different transmission routes that occur with water, soil, and even cough aerosols now. There's been a lot of evidence paid to water, a lot of attention paid to water, but what's the evidence? There are a wide variety of species of NTM identified in water samples, but not all of them can cause disease or have been associated with disease. And to prove it, you really need to match the genotypes from the patient with the water. And that's been done for household and municipal water systems for AVIUM, abscessus, Kansasii and lentiflavum. And then hospital water outbreaks have been associated with porcinum, AVIUM, abscessus, fortuitum and chimera, but not for intracellulari. This is what I mean by the genotypic matching of clinical environmental isolates. And this is a fairly old study now, but we did some Brisbane water sampling and found 13 abscessus isolates in the water. And we then looked using rep-PCR at the water isolates versus the clinical isolates. And you can see these arrows here are pointing to water isolates, and the rest are clinical isolates. You see that the patterns are matching. This is over 90% similarity between clinical and water isolates for this pattern and this strain pattern. This has since been confirmed using whole genome sequencing that the organisms from the water match those of the patients. I've already pointed out the fact that Mycobacterium avium complex is now a wide variety of subspecies, or individual species, I should say. And what we thought was intracellulari in water has now been looked at in more detail, and those isolates that were thought to be intracellular were actually all chimera isolates. So intracellular has not really been associated or definitively associated with water sources. So these organisms do grow in our pipes. They survive the treatment. They come from the source water. They survive the treatment of filtration and disinfection. They grow on filter media. They form biofilm on the media in the filtration systems and inside all of the pipes, and they grow in the system such that the numbers of organisms that are collected just downstream from the treatment plant grow 25,000-fold to the numbers that come out at the tap. So they are proliferating in the system. The further you get away from the treatment plant, the lower the chlorine levels. There's degradation of disinfection, and the time in the system is also significant for increasing NTM. NTM also have this ability to form bioaerosols, that is, aerosols containing organisms. And they can be naturally aerosolized from lakes, oceans. Some very cool studies back in the 1950s looked at petri dishes floating on the water and were able to grow Mycobacteria on those dishes. And this leads to a 1,000-fold increase in the numbers of mycobacterial cells per mil that can then be inhaled. And these can form droplets of a respirable size that get right down into the alveolar ducts and set up distally down here and form biofilm and proliferate. And this first came to our attention when these reports of hypersensitivity pneumonitis associated with hot tub lung came out. And people who were using these hot tubs where the water hadn't been changed very regularly, they were indoor hot tubs in a cold climate, and these people got this very similar disease to bird fancier's lung, which is a hypersensitivity pneumonitis. AVIUM was grown from the filters, from the steam that's coming off the hot tubs, and from the bronchoalveolar lavages from these patients. And then there was there's been another report where metal workers developed the same sort of disease. The workplace health and safety people decided they should disinfect the fluid that was being used for grinding and metalworking. They disinfected and killed everything else. Mycobacteria overgrew, and then we got this problem. The same interest has gone into showerheads, and people have looked at sampling showerheads for mycobacteria, both using cultures and non-culture techniques that have shown that the showerheads are very rich in NTM. And we did a study in Brisbane looking at home sampling and growing aerosols from patients' showers, so using an Anderson impactor to suck steam in while the shower was running. And we grew AVIUM abscessus and Kansasii from shower aerosols of patients that had disease. But there's also bioaerosol generation when you have raindrops hitting the soil. And this was a rather cool study that was published in Nature that looked at what happens when rain hits soil and how the organisms then attach to the aerosols and how they're transmitted around the world. And you can imagine what happens in a cyclone in North Queensland, where you've got wild winds and wild rain and soil rich in mycobacteria, and how that may result in spread of disease. And they looked at different types of soils, and they felt that most of the bioaerosols were generated on sandy clay soils, but as opposed to plain sand. But there are a whole lot of variables that affected that. There have been quite a lot of mycobacteria isolated from soils. A study in the US, they got all their patients to send in their potting mix and their home soil, and there's a wide variety of species, plenty of AVIUM, plenty of intracellular. This is what the patients had, AVIUM and intracellular, and a few others. There have been quite a few studies in Japan that have again looked at AVIUM and intracellular in patient soils and matching them with patient isolates. The American study also looked at what happens when you pour soil and the generation of aerosols associated with that, and you can certainly grow NTM from soil aerosols. And there have been some studies that have then looked at population surveys of risk factors for NTM disease, in terms of environmental exposures. And this study here was done in an area that had predominantly AVIUM disease, and their water exposures, showering, doing the dishes, swimming, weren't associated associated with disease, but these soil exposures certainly were. So if you worked in a soil occupation, you were planting on farms, driving trucks on farms, or you owned a landscape service, then you had a significantly higher risk of NTM. And this seemed to go up according to the length of time that you participated in the soil-related occupation. So this is certainly raises a few issues with work cover and occupational health and safety in a lot of these type of occupations, and personal protection, etc. David Dawson, the former head of our laboratory in Queensland, did some studies back in the 70s looking at house dust, and he got patients to bring in their vacuum cleaner bags and looked at the prevalence of NTM. And one of the first strain typing techniques that he developed was this serotyping, and when he looked at the strains of NTM he grew from the vacuum cleaner dust, he found there were about 50 that were intracellulare, and 44% of those were the same serotype as the serotypes that he was seeing in the patients coming through the lab. And this hasn't really been repeated, but there has been another study that looked using DNA, 16S DNA sequence analysis, and found quite a wide variety of mycobacteria that are found in dust. And then if we look at NTM survival, we know that TB itself can survive on dry surfaces from anywhere from a day to 4 months, and that mycobacteria are really quite resistant to this infection. And if you look at the resistance compared to other bacteria, mycobacteria are certainly up there. This is a slide that came from a science paper which was published in 2016, looking at the spread of Mycobacterium abscessus amongst patients in a CF unit over there. It was a very big study looking at whole genome sequencing, where they were able to demonstrate that perhaps they felt quite convincingly that there was transmission from patient to patient somehow within this cystic fibrosis unit in Cambridge. And this is a demonstration of what happened in that outbreak. This is patient 1 who is smear positive, culture positive for Mycobacterium abscessus, and goes into hospital for treatment into this particular patient room, is there for a few months for treatment, becomes smear negative, so smear negative, culture positive, eventually is discharged but is still culture positive and stays out of that room for the next few months. Patient 2 comes along who's had negative cultures, goes into that room for a short stay, comes home and eventually becomes smear and culture positive. Patient 3 has multiple negatives, then goes in for a short stay, comes out and starts to have positives. Patient 4 is negative, goes into that room, comes out and is positive. This patient then comes back in and has more stays, and then they realise that something may be going on with this room. They start to do some environmental sampling, and these are environmental samples from that room that were positive. The cleaning process was then changed here to be more intensive and to use a slightly different cleaning regimen, and the environmental samples then became negative. And there have been other studies that have shown the ability of M. abscessus to survive in fomites and to be able to resist cleaning and to resist desiccation and drying. So you think, well, we just let it dry out, that'll be fine, but actually abscessus is really very hardy. And there may be some genomic changes that have happened over time with abscessus that have made it more resistant and more able to survive in these sort of environments. So just to summarise then, NTM disease is significantly increasing all around the world, and it's not just an increase in diagnosis, there's other things going on. There's definitely geographic variation in species distribution around the world in both the patients and in our environment, and even within our environments. Within the state of Queensland we have different clusters of different species in different areas. And there are things that we as humans are probably doing that are influencing the numbers of mycobacteria in the environment. For example, what we're doing in agriculture, what we're doing in mining, how we're disinfecting our water, how we're heating our water. Things like the temperatures of our hot water system have been associated with NTM outbreaks. The pathogenic evolution may also enhance transmission. I know Andrew will probably just allude to this the smooth and rough morphologies of abscessus and their ability to then form aerosols and be transmissible patient to patient. And we have grown abscesses from cough aerosols from patients, suggesting that patient-to-patient transmission may be well and truly on its way. And for those of you who are a little nihilistic about notification of NTM, we do need to have some sort of surveillance systems to track these changes. And a lot of the studies that we've done have been on the back of having good notifiable data and being able to look at the geospatial distribution, changes in environmental loads, to see whether there's stuff that we're doing that may result in outbreaks. So that's actually half an hour. I'll stop there and take questions.
Okay, thank you, Rachel. Can I ask if there's any questions for Rachel? I was going to ask a quick question about, although they're ubiquitous, are there any measures that you get consulted about which should be put in place in high-risk places for how to stop this?
Patients ask that question all the time, and there's really no evidence to say if you do this you won't get it again. But I think if you have someone who works in a fernery or in a gardening system who has a lot of soil exposure, I've had patients who work in heavy machinery on farms, for example, and quite often you see them grow different species, and you can see in their sputum samples, not all associated with these, and you can see that they're probably just acquiring it from their environment. Well, you could recommend, makes sense to recommend that you wear a mask and have personal protection in those high-risk situations. Certainly things like the hot water system temperatures. There was an outbreak of AVIUM in Philadelphia where they all turned their hot water systems down to 45 degrees Celsius, which is really very low. That's lukewarm. And they had a high rate of AVIUM up there, and then they got everyone to turn them up to 55, and that all went away. So the temperature of the hot water system is important, and we've all been through phases of turning it down because of risk of scalding children, saving energy, those sort of things. I think we need to make sure the temperatures of those systems are up. Avoiding hot tubs. I don't go so far as to say don't shower and have a bath because we're in Queensland and everyone's hot and sweaty. But there was a Japanese study where they used lots of baths in Japan and they could still grow it from aerosols off a bath, so I don't tell people not to do that.
Rachel, it's Ben from Sydney. I wanted to ask about the change in phenotype that you commented on early on, where you said originally we saw lots of NTM in this fibrocavitary disease, and we're now seeing a lot more of this bronchiectatic type spread. Have you looked at any differences in the risk profile of those patients or the species associated with those disease phenotypes, which seem to be very distinct phenotypes?
So the question is there a difference in the species associated with the nodular bronchiectatic disease?
Either the species or the patient risk profile.
Patient
risk profile. Whether are the patients similar? Is it similar groups of patients who present with these different phenotypes?
In terms of the phenotype, well, there are other phenotypic features associated with those nodular bronchiectatic people, and there have been some studies that have shown that they're taller than average, they're thin, there's an excess of pectus excavatum, mitral valve prolapse, there's an overlap between connective tissue disease features, some immune features, and some features of cystic fibrosis where they have excessively thick secretions. There's a large number that have CFTR mutations. Over half in one study showed that they have CFTR mutations. Have diagnosed a lot of patients with atypical CF where they have a CFTR 508 and a lesser mutation that confers changes to airway secretions that presents as CF in older life. There have been some genetic studies of those Lady Windermere nodular bronchiectatic patients that have narrowed down to those sort of four areas: ciliary disorders, mucus quality disorders, immune and connective tissue features. And at the moment, there's a big GWAS, international GWAS study underway that's trying to hone in on where the genetic defect is in that sort of patient. In terms of the species, there are some that seem to be more associated with cavitary disease, like Xenopi and Kansasii and AVIUM. Intracellulare seems to be the most common cause of the nodular bronchiectatic type. But again, that depends on where you live. Like, we see a lot of intracellulare here in the US. Canada see a lot of AVIUM and Xenopi. So the climate does affect what's in the environment.
Thanks, Rachel. Okay, with pleasure, I now invite Andrew Burke to come up and present to us. Andrew's an infectious disease and thoracic physician from the Prince Charles Hospital. He's also doing a PhD trying to understand the pharmacokinetics of antimycobacterial agents, some data which is desperately required. As I found out on Google, he's also a famous Australian poet, but not this Andrew Burke, of course. So, yeah, not this one. So
doing background check on all your speakers.
I am. So if there's any rhyme from this one, I don't think that was intentional. So thanks, Andrew.
Okay, that's an interesting introduction. Thanks, Jason. So thanks for coming. So I put this together, and this program, I just literally put the NTM at the start, because I put it at the end, all the ID people might run out after the TV stuff, because generally speaking, you know, respiratory have been owned NTM for many decades, I suppose. And if you go to an infectious disease conference in America or ECMID, there's no sessions on NTM. Whereas if you go to the American Thoracic Society meetings, there's whole plenary sessions on NTM. So in some ways, it's a bit like viral hepatitis. You know, the gastro people have owned it for many decades until we sort of jumped on board more recently. And so it's nice to have some ID people here to hear about NTM. And when I did my ID training, finished a decade ago, I don't think I ever looked after somebody with Mycobacterium abscessus, and maybe that's because we weren't diagnosing it. Rachel's forgotten into this, but certainly now there's more interest among the ID community. Just one disclosure: MSD have given them some funding for some susceptibility testing. So this is just a rough outline of my talk. So I spoke at ASA last year on abscessus, and I'll cover some similar ground. I thought this year I might, at this talk, I'm going to talk a few more case studies and try and, in the middle of the talk, and speak a bit about abscessus in the context of some clinical case discussions and how we go about approaching that. And certainly with the case studies, I'm not saying how I do it is perfect or the best evidence or is the only way to do it. There'll be differences of opinion maybe, but I think in terms of just the overall approach to how we treat and move forward in abscessus, hopefully it will illuminate some aspects. So I thought I'd just start with just two simple case studies of patients I've been involved with in the last few years. This is a 58-year-old mechanic who many years ago now presented to another hospital with some mild hemoptysis. And this is certainly in Brisbane. We've been lucky to have Rachel's mentorship and leadership and Chris Coulter's about getting a lot more corporate knowledge about NTM. But I think back in 2012, we probably weren't as, across our city at least, we probably weren't as taking abscessus so seriously. This guy presented, he had a bit of hemoptysis. He had a bronchoscopy looking for cancer, and that grew abscessus subspecies Belledii, and we'll talk about the speciation a bit in a moment, as Rachel has touched upon. And you can see he's got a cavity and some other change here in the right middle lobe and elsewhere. And then he was watched with an X-ray 3 months later. He had no further hemoptysis, and he was discharged from the service. And he presented about 10 months later with a much larger volume of hemoptysis. And you can see here, this really very large cavity now, very pronounced nodular change and multilobar disease. And the interesting thing about this guy is that he really had no clinical signs to suggest that this was happening. It had no symptoms for 10 months, a bit of hemoptysis, and presents 10 months later with very marked trajectory, I think we'd all agree. And you know, if this was tuberculosis, he would have been very sick in that intervening period. He would have had a suppurative lung disease, coughing up a lot of phlegm, losing weight, fevers. And so there's something about abscessus which it seems to fly under the radar somewhat in terms of the host response. And he's had multiple courses of treatment, and 8 years later, he's still smear positive, but it's interesting the trajectory is really settled. Even though in 10 months he progressed very, very badly, he's really plateaued. And so I think he's put a little bit of weight. He's got a attentive wife who feeds him up a bit, and you know, maybe some of those things have tipped the host balance in favour of stabilisation. This is a 19-year-old woman we saw about a year ago. She presented with 6 months of cough, otherwise completely well. I think she was in childcare as a student, and she had some sort of soft consolidative change here. down the right base and maybe the left base. And on CT scan, it's probably hard, but she's got some subtle bronchiectasis and some minor inflammatory change here in the right middle lobe and elsewhere. And she grew abscessus subspecies nasilense. We'll talk about the taxonomy in a moment. And this is unusual bacteria to have in a 19-year-old woman, otherwise well. And she also had Haemophilus and Staph aureus. And as part of our protocol, which Rachel's alluded to, we screened her for cystic fibrosis, and she had a delta F508 and an Alabari mutation. So she had an atypical variant of cystic fibrosis. And even though she would have been screened for CF as a child, as a neonate, this wasn't picked up upon. So it's probably, certainly, I think it's appropriate to screen for CF in some of this population. Now she had, unlike the first fellow who's still smear and culture positive 8 years later, she had a rapid response, to therapy. She actually stopped her IVs after a couple of weeks because she felt well and she wanted to go back to uni. And she's been put on ivacaftor and she remains very well and culture negative after a relatively short duration. So Rachel already showed this slide, and this is, I think the main thing for me is just to say that the abscessus wasn't really identified before 92, and a lot of what in the historical literature of Mycobacterium cheloni being having progressive bad disease was probably abscessus, but it just wasn't. It was misdiagnosed or misclassified at that time. And this taxonomy now is sort of important because nasilense, as I'll show you later in the talk, has a much more favourable outcome. About 80% plus will get a cure, and that's related to its macrolide susceptibility. Whereas abscessus and Bolletii, they tend to be grouped together in terms of our lab identification, and they have a much less favourable prognosis, again, probably in part related to its macrolide resistance. So in Australia, roughly, others can correct me, but I sort of think of it about 45% abscessus, 45% nasilense, and about 5% Bolletii as a rough breakdown. So this is a study that came locally out of the Alfred Hospital in the CF population, and I think it's sort of good in that we always struggle about when to treat. And I remember Rachel has always said that TB is quite easy because you always treat TB. You don't have to go through these mental gymnastics and hurdles about whether do I treat or not treat. But for NTM, we often do have to go through this. And this is a study looking at longitudinal isolates, and the red dot is the first ever abscessus isolate in a CF patient. So all these rows here are separate patients, about 40, and about a third of them only ever had one isolate. The other blue dots are other atypical Mycobacterium, and the grey dots are negative sputum. So roughly a third of them had one abscessus isolate, and you never saw it again. Another third, the orange dots here, are ongoing abscessus isolates. So they had a few more isolates sometimes over years, but eventually they cleared by themselves without treatment. And the lower third here had multiple isolates, and a subgroup of these required intensive treatment. So it's often hard to predict, who's going to clear and who's not going to clear. And the flip side is we don't have to rush in and treat everybody on their first abscessus isolate. So we can follow these people, make decisions often over months or years in the CF community. Certainly, if someone's got sort of severe cavitary disease in a non-CF group, we would generally go in and treat straight away unless we felt their life expectancy was very limited. So it's interesting coming back to about why are we seeing more of this, and it's been hypothesised that maybe abscessus is evolving or adapting to a more domestic environment and to environmental and human niches. So generally in the environmental reservoirs, they tend to have been smooth phenotype. So this is on solid media what it looks like, and then under electron microscopy, it's smooth. And then these are the rough phenotypes here, and they get this cording, which is a bit like what we see in TB as virulent strains of tuberculosis. It can have this cording under electron microscopy. And it's been suggested that when people are predisposed to maybe cystic fibrosis patients who already have bronchiectasis, so they're within the bronchiectatic airway, they get colonised with a smooth variant, and then they lose this glycopeptidolipid outer coating, which allows it to sort of mask itself a little bit from the host immune system. They then they develop in the human host, if you like, this rough phenotype, and this can then has a few things. One is it becomes resistant to macrophages. It increases TNF-alpha, it can increase the damage to the host lung, and it also becomes somewhat hydrophobic and more able to be generated in aerosols. Maybe coming back to this idea of patient-to-patient transmission. And if you look at the evolution of tuberculosis, a similar thing may have happened. So TB is Mycobacterium kansasii is the ancestral precursor for TB. It's been around for millions of years, and that tended to be has a smooth phenotype. And then the TB around 10,000 years ago became endemic in the human species, and that also has more of evolved having a hydrophobic sort of aspect, so it could be transmitted in cough aerosols. And maybe we're seeing a rough parallel here in non-tuberculous Mycobacterium in abscessus. This is a study I liked, looking at people who are treated for Mycobacterium abscessus with amikacin. So this is your standard MIC strip. And what they found is in the sub-MIC zone here, so this is the area where you're not getting complete killing of abscessus from amikacin. You can see here maybe a different morphology on the solid media. Okay, so an astute scientist noticed this. So it's different, even though it's growing, it's a different phenotype to what you see outside the MIC zone. And when they looked at this under the microscope, they found that in the presence of amikacin, they got this cording again, and they found that this was promoting really a rough phenotype. So the punchline of this article was that if we gave ineffectual doses of amikacin or sublethal doses of amikacin, we may be generating out more resistant strains of abscessus, which may be then becoming perhaps more able to be transmitted between patients. And although it wasn't discussed in the discussion section of this paper, I just wonder whether in the CF population, just an idea, that we expose a lot of these young kids to tobramycin regularly, and could that be in some way changing the abscessus that we're seeing in our CF young patients to maybe more of a rough phenotype? So the genome of abscessus has been sequenced now fully, and as a result, we're starting to get an idea of why is it so resistant. So this is really among the most resistant of all infections that we treat, and that's one reason why ID physicians are becoming increasingly interested. So if you look at Mycobacterium cheloni, which is very similar to abscessus, its cell wall is about 20 times thicker than for TB. Okay, so we tend to think, well, why don't drugs that work for TB work for abscessus? And there's a number of different resistance mechanisms which are at play here in abscessus, which aren't necessarily present in tuberculosis. So, and I'm going to go through these in some detail, but essentially beta-lactams are generally fairly ineffectual against Mycobacterium abscessus, and there's this beta-lactamase abscessus or blamab, which inactivates most beta-lactams, that I'll go into in a moment, and likewise for macrolides and for the rifamycins. So generally, cafoxylin and imipenem are the only beta-lactams which are felt to have activity in abscessus, and the rest are inactivated by this blamab, so beta-lactamase, specific to abscessus. There's a number of different beta-lactamase inhibitors now, which may lower the MIC quite drastically of some of these other beta-lactams. So ceftazidime avibactam, that's already used in Australia. We use it for resistant gram-negative infections, including Pseudomonas. Although ceftazidime is not effective against abscessus, the avibactam, as a beta-lactamase inhibitor, can certainly lower the MIC quite drastically. So even for, say, amoxicillin, which is an MIC of greater than 256, so ineffectual, some of these beta-lactamase inhibitors have lowered the MIC for amoxicillin to like 1 to 4. Okay, so quite drastic. Likewise, meropenem avibactam, which is FDA approved for drug-resistant gram-negatives, has been shown. Again, the avibactam there being the parent agent, and imipenem relebactam, which has again just been FDA approved last year. The relebactam seems to have a significant effect in inactivating these beta-lactamases. So there may be sort of other synergistic combinations that we can use, taking advantage of these new beta-lactamase inhibitors. So with macrolides, so macrolides are really the cornerstone for NTM treatment in most situations. So one thing which has increasingly been shown in the last 5-10 years is this dysfunctional ERM gene or ERM41 gene, creating inducible resistance in abscessus and other NTM, essentially abscessus. So that's why we culture or expose abscessus for up to 14 days for clarithromycin to see if we can unmask this ERM mutation. There's also the constitutive resistance that can occur just as you can with any type of resistance process for antibiotics. And certainly treatment outcomes seem to be quite clearly linked to the subspecies. So Massiliense are less likely to have the ERM41 gene mutation and therefore less likely to have inducible resistance to macrolides. So this is again just trying to link that ERM mutation with macrolide susceptibility and outcome. This is looking at the proportion of patients who remain culture positive in the vertical axis here. So yeah, everyone's culture positive. And then depending on whether you had a resistant or sensitive genotype, again based on the ERM mutation, it really depended whether you were going to be, or strongly influenced whether you're smear or culture positive many months down the track. So most laboratories won't actually specifically test for the ERM mutation, but they will be 14-day clarithromycin susceptibility, which is really, in many cases, a surrogate marker. So one drug which has become, I've started using just in the last 6 months, is rifabutin. And so rifabutin has been identified as potentially useful oral agent, of which there are a few for Mycobacterium abscessus. So rifampicin has no activity against abscessus with an MIC of greater than 256. And what they've done is they've looked at high volume throughput screening of drug libraries. So they've screened about 2,000 different agents. And for those who inhibited growth by 80%, this is above the red line, these were drugs which were found to have some activity against abscessus. And one of those which was unexpectedly above the red line is rifabutin. And that was then looked at in more in vitro studies, and that was verified in a number of different settings. And other drugs which were above the red line were drugs like you would expect, like teicoplanin, but the levels that you would have to, or the doses you would have to give would be prohibitive. But nevertheless, some interesting sort of drugs have come up on these drug library screenings. So the great thing about rifabutin is that we have some experience with it as ID and respiratory clinicians. There was synergy demonstrated in hollow fibre models with tigecycline and clarithromycin. And even in those people who had macrolide resistance, it seems to sort of, restore some degree of macrolide susceptibility. So one of the big negatives is that it's contraindicated because it's obviously CYP450 interaction. Most CF patients now are on these new gene therapies like ivacaftor, and unfortunately rifabutin is contraindicated. But now, as I'll show you in some of the case studies towards the end, if there's no contraindication of rifabutin, I'm starting to use it in the oral phase. So one of the difficulties has been trying to make sense of a lot of the susceptibility profiles and how can we try and test some of the different combinations. So there's been a lot of work now on hollow fibre modelling in mycobacterial disease, and there's probably 2 or 3 labs in the world who probably produce 90% of the publications on this. So the reproducibility of these studies between different laboratories with different isolates hasn't, to my mind, been demonstrated. But it's probably useful at testing a number of different hypotheses and different combinations. So many of you will be familiar with this, but what hollow fibre models are is really allowing us to try different combinations and try to mimic what we see in the host lung, in the complicated environment of a bronchiectatic lung. So it's a bit like having a dialysis filter where you have thousands of different filters, and you can run fluid in there with different combinations of antibiotics, and you can sample this port here. There's different chambers where you can sample. So you can incubate this. This is like a bioreactor. You can incubate Mycobacterium abscessus, alter the pH, alter the drug concentrations, try different combinations. And as well as changing the combinations and the pH to try and mimic what happens in the patient, you can then try and look at how are we going for selecting out different resistance, again, and how bactericidal are some of these combinations that we're trying to use. And look, I think it's, as a clinician and an expert in the technology, I find that they are coming up with some very interesting combinations, but the problem is that translating those to the patients is often a bit fraught. So, for example, some of these studies say, well, tigecycline is the best drug for abscessus, but then if you read the second last line of the article, that you need 400 milligram, for huge doses to take advantage of the area and the curve targets they're suggesting, which are just not practical. So there's a bit of tension in the mycobacterial world about those who are strong advocates of using the hollow fibre model system to what we can actually use in our patients in terms of actual toxicity that we see with some of the combinations recommended. So this is just one template for treating abscessus, and there's a couple of different position statements that have come out, which I'm going to show you in a few moments, just to make you aware of them. And certainly I think the ID physicians here probably wouldn't read these journals regularly, so you may not be aware that these quite well-written documents exist. So one is in Thorax, which is the US Cystic Fibrosis Foundation, European CF Society. They came up with about a 20-page paper on how to diagnose and treat non-tuberculous mycobacteria, including abscessus. And what they say is that you have an initiation phase and a continuation phase. And the initiation phase includes 2 to 4 to 6 weeks of IV therapy. It could be imipenem, tigecycline, ramicasin, along with a macrolide. And then you have this sort of prolonged continuation phase. And that can include drugs like clofazimine, minocycline, quinolone, and nebulized amikacin. Now, some of this, like minocycline, has subsequently been shown to have very poor activity against abscessus. So I probably wouldn't use minocycline now, and quinolones probably aren't as effective as we think in abscessus. So certainly there's a fair bit of geographical variation. In South Korea, where they do a lot of abscessus research, moxifloxacin seems to have better activity than it does in other parts of the world. So this is really just giving you a bit of a framework of where to start. So cafoxin is another drug that traditionally we've used quite a bit of, Cafoxidin has the advantage of being stable in Daxa bottles, so if you're giving it as hospital in the home, you can give it through a dual lumen PICC line, and so that has the advantage. One of the problems with cafoxidin is that people seem to get a leukopenia and can get liver function test arrangements with prolonged use. So it's fell out of favour a little bit. There's also been a recent IPD where they looked at a number of different studies, and imipenem and ticacycline were shown to be those with a more favourable outcome, whereas cafoxidin is a little bit less favourable. So this is the other major paper that's come out, which is a BTS Society guideline, British Thoracic Society. Some of the authors are the same, and some of the recommendations are very similar. Here they give some dosing recommendations. Okay, we probably give a higher dose of amikacin, 25 milligrams per kilo thrice weekly. Again, they suggest ticacycline, imipenem, and macrolide, and the continuation phase is very similar. And as I mentioned, there's these potential new agents which are expensive but can be accessed. And certainly some of our colleagues in Canberra have used ceftazidime avibactam, but you're looking at many thousands of dollars a week to try some of these drugs. And tadizolid has also been flagged, as has linezolid that they've used in some situations as well. So if you look at the cost of these drugs, we did a cost for our high-cost drugs committee, and if we're giving people a month of IV therapy, we're looking at about $20,000 a month, okay, including the cost of Daxa bottles and all the disposables that come with that per hospital in the home. So it's really a very expensive combination that we're often suggesting. So I thought now I'd go through a few case studies about 10 minutes ago. And again, these are, I'm not saying there's only one way to manage these patients, but just to try and put a framework around how we approach. They're patients I've looked after in the last 6 months, and they're still on treatment. So a 72-year-old male retired pilot, he's had sporadic hemoptysis over 3 years, seen by a private specialist who had isolated Mycobacterium abscessus and felt that it was probably not really indicated to treat at that time. And he really had minimal symptoms, but he had a few other cases of fairly modest hemoptysis, and had seen another private respiratory physician 4 or 5 months ago referred him to me. And he's got a sort of cavitary disease, which has very slowly progressed over 3 years, but otherwise looks extremely well. He's 72. You wouldn't be surprised if he lived to 92 or 102. So he's someone who I expect is going to live for decades, which sort of influences your decision to treat or not. So there's a couple of options. One is that you can say, well, look, he looks very well. This is not interfering with his life. Can we just observe him? And in some ways, that's, by the time I see him, I've got the advantage that it's been observed for a couple of years. He hasn't cleared. He's still smear positive in multiple samples over several years, and his radiology has progressed. The option is you could sort of treat now, and the option is, well, let's just never treat because he's 72. What about, and you know, what do I say to the patient? This guy feels very well, and I'm sitting down and telling him he's got a very multi-resistant pathogen, and he's saying, what will happen if I don't treat? This is a paper which came out last year, last month out of South Korea, where they followed patients for about 12 to 15 years, and trying to predict what would happen versus, not so much treatment versus no treatment, but different isolates, okay? And this guy should say had Nasiliense, which you might remember is macrolide susceptible and has a better outcome. So those people who had Nasiliense, which is a green bar here, they seem to have a pretty good long-term survival. This is cumulative survival. Whereas those who had abscessus, here they differentiate between Nasiliense and abscessus, although sometimes we call them the same, they had a worse outcome. And those who had Mycobacterium cellularare had a worse outcome. And likewise, they've looked at the cavitary versus non-cavitary and fibre cavitary phenotypes. And they found that those with fibre cavitary, like he did, had a worse survival, as did in this group males did as well, and those who had cancer and other things which you would predict would have a worse outcome. So I guess you can say, well, there's a chance that for this guy who otherwise may well live into his 90s, there's a chance that this is going to catch up with him and impair his quality of life. So in January we started IV amikacin, IV ticacycline, and imipenem, and he's on 6 weeks of that. He's IV amikacin I stopped 2 weeks ago because he had some hearing, objective hearing loss on audiometry, which he hadn't noticed himself. I switched him over to nebulized amikacin, which unfortunately he's got quite bad hoarseness on. But he's otherwise tolerated his IV therapy very well, and you know, we've managed getting out of hospital after a week or so and having him on home IVs with 3 IV agents now, which is tolerating very well despite his age. So I think often there's this thought that NTM treatment makes everybody feel sick and the treatment's worse than the disease. But for many of our patients, I'd say the majority, they can tolerate it quite well with some spruiking here and there of different doses. And I've added in rifabutin to him, and he'll be on this treatment of continuation phase probably for a year or so. So this is another lady I saw late last year, a 52-year-old Japanese woman. She's Australian now, but she's of Japanese ethnicity, which is relevant because certainly in North Asia there's some interferon gamma antibodies which can increase the risk of NTM infection, which she's negative for. But she presented again like this guy very well, but had a minor hemoptysis over a year. She's had a CT which has shown progressive disease, some cavities and again some progressive changes. Now she's got 3 sputa positive for Mycobacterium intracellular and 1 sample positive for Mycobacterium abscessus, subspecies abscessus, so it's macrolide resistant. So what do? Do we treat the intracellular, which can often be treated with oral therapy, a bit easier to treat? Do we treat both? Do we treat just the abscessus? So this is the abscessus resistance profile that we get. And again, she looks very well in herself, but if we're trying to treat the abscessus, we can say, well, she's intermediate to cefoxitin, there's lots of R's here, and there's a sensitivity to amikacin resistant to clarithromycin. So there's a few possibilities for this lady. I'm not saying either is necessarily right. We could observe her, but she's 52, and there's a chance that this is going to, we definitely want to treat the MAC. Do we treat the abscess at the same time? Well, we can come back to how we guide that decision. We could treat the MAC only and come back to the abscessus later if we find it. Now, one of the issues about treating, ignoring the abscessus is if they're macrolide susceptible abscesses, then you're then exposing abscessus to monotherapy macrolide, if that makes sense. And you may be then generating macrolide resistant abscesses and burning your bridges for future treatment options. But she's already macrolide resistant, so maybe that's not so important. Or do you treat them both together? So if you look at the susceptibilities and trying to interpret these results that the laboratory give us, if we just look at clarithromycin first of all. So this is abscessus, only 20% susceptible to clarithromycin, Ledi about 40%, and Massillin about 98%. And you'll recall that these tend to be predictive of outcome, whereas for all the others, there's really no clinical correlation. And the laboratory are always very good at saying no clinical correlation, okay? So one reason for that is that there just haven't been the large numbers of clinical studies to try and have a PK-PD endpoint or PD endpoint for clinical outcome and matching it. When you've got people on multiple therapies, how do you untangle which drug is effective or not? There's also this concern about the MICs that you're getting in the RAPI plates that we use. Maybe they're exaggerating resistance. So what do I mean by that? So this is a study that came out a couple of years ago looking at the relative contraindication of the drugs in the wells that we're using. Okay, so cefoxitin, imipenem, meropenem. So with cefoxitin, they found that over 3 days to 6 days, and the plates are usually read between 3 and 5 days, there was a significant decrease in the active drug that we're measuring these isolates against, and that the MIC creeped up, not surprisingly, because the drug concentration is dropping quite markedly. Likewise, with imipenem, the active imipenem is very unstable at room temperature. That's why I don't like using it as hospital in the home. So it's unstable in Baxter bottles. It's probably unstable potentially in their RAPI plates. So the imipenem is becoming very unstable, and the MIC is increasing. So I guess the flip side of this is maybe these drugs are actually better than we think they are, at least based on in vitro susceptibilities. Likewise, for clarithromycin, it's been suggested this may degrade with time as well. So there's caveats that even though things may be resistant, maybe they do have some activity. So this is, again, that's the same thing, the same schedule, just to remind you. So I admitted for bronchoscopy the day of admission. I started on therapy to cover both abscessus and MAC, and I added in ethambutol, which would cover the MAC as well as the abscessus. And the bronchoscopy flagged positive on the liquid media on day 5, so I thought, well, she's probably going to have a rapid grow, but it turned out to just be MAC actually after all. But I've elected to treat her for both abscessus and MAC at the same time, mainly because she had cavitary disease, she's young, she's probably got the most to gain by treatment, and she's tolerating her therapy quite well. And so what I've done is, because of the, normally for MAC I just give rifampicin, but what I've done to her is instead of giving rifampicin, I've given rifabutin, so I can sort of get some activity against abscessus at the same time, if that makes sense. My final case, and I'm finished for my session, is what to do with treatment failure. Okay, so this is a lung transplant patient. He's a young guy by pulmonary fibrosis standards, had a lung transplant about 3 years ago. Great outcome. His main complicating factors have been recurrent hemoptysis from abscessus, and he's got this sort of blushy sort of change here, ground glass change through multiple lobes. So it doesn't look that exciting compared to cavitary disease, but he's got this diffuse change throughout lungs, which is felt to be abscessus. Nothing else is growing like fungus and bronchoscopy. Smear positive on every sample. He's also got these stents put in because he's got this sort of granulation stricture of the main bronchi. So he's got metalwork in there, and he actually had a dehiscence around his stent. you can see that little sort of blind alley there. So the concerns for the transplant physicians is this abscess was 3+ in the bronchoscopy when they swabbed this, and they felt that this dehiscence was basically due to the abscesses. Okay, so even though it looks very well, it can walk 5 kilometres, people are worried that his transplant is going to one day catastrophically collapse. So he's had multiple courses of therapy over 18 months. Cafoxamine LFTs went up to 1,000, imipenem severe nausea, Ronezlid severe nausea, and his most recent regimen he's been on amikacin for 3 months, other combinations you can see. And in January, I added imbedaquiline, which we've used in a few cases now, and seems to have in vitro activity. And there's a drug liposomal amikacin for nebulization, which Rachel will speak about in the next talk, which I got on compassionate access, so that's available now. And look, it's a single case. He's in bedaquiline. He's now culture negative the first time in 3 years. Obviously early days, and his CT showed marked improvement even a month later. Now, this is level E evidence, okay? But it's just to show that these drugs are available, okay? And they may, in vitro, they have some activity, and there may be other options you can try for your difficult patients. So just to summarise, we're seeing more abscesses, maybe evolving, as Rachel's alluding to. Treatment's very costly, and the optimal treatment regimens remain uncertain. And Rachel's going to talk about some other trials that are underway to help answer some of those questions. So I've got a little bit over.
That's excellent, Andrew. Does anyone have any questions for Andrew? Just while we're getting the microphone across, I want to ask one about hollow fibre model and the value of that versus just static time kill curves, whereby they're just fixed concentrations, because obviously there's a big cost differential in those. What do you see the relative merits of those, and whether or not there's a potential in the future for them to become available for these really difficult cases to try and find personalised combinations of antibodies?
So with the hollow fibre models, I guess one thing is it's experimental. It's very interesting, and I'd like to see the laboratory share their isolates to see if they get the same results, firstly, because there's only 2 main labs that I can see who are doing it. The great thing is they're trying to mimic what happens in a cavity or different low pH environments where you get variations. And in my next talk about PK, I'll discuss this further, where you get very different pHs and you get very different conditions for bacterial growth in different compartments of the lung. And the hollow fibre can look at that. It can also look at what is likely to select for resistance. So I think that's very good. What it doesn't do is really tell us about drug tolerance. And so I think there's a bit of a gap here in, certainly it's very useful, but in isolation, I think there's a little bit too much weight is put on it. Or there's a danger of putting too much weight on it. That's where we as clinicians help to provide that advice. So I think there needs to be more of it. It's coming up with novel combinations that we haven't thought of before. But there's a little way to go, I think, in terms of rolling it out routinely. Okay.
Thanks for your talk, Andrew. I was just wondering about where surgery might fit into some of these patients and when you've thought of that in cases.
So thank you. So I didn't have time to talk about it too much, but certainly we have done surgery for some patients, for people with a single cavity, even if they have other sort of nodular change in other lobes. In Denver Jewish Hospital and Korea, they've published in cohorts of maybe 30 to 50 patients looking at that. And if you've got a dominant cavity or dominant lobe, then certainly surgery, I think, should be considered. We've had, unfortunately, 1 or 2 suboptimal outcomes recently, which have made us gun-shy about surgery. So one patient she had just fairly isolated middle lobe disease. It was resected, and then she got pleural seeding, and she got tracking of the abscesses along the port sites, and she had quite extensive debridement. It's not subsequently done well, but it really needs to be done in an expert centre with somebody who, ideally one thoracic surgeon who's got an interest in this and is doing it as much as anyone can. Okay, so in Brisbane we've got one surgeon who does it. He might do a few cases a year. So I think there's a role for people with good lung function who can do without a little bit of their lung and have localised disease. But we have had one case not do as well as we would have hoped. Tim.
Thanks, Andrew. Getting thoughts or guidance on using antibiotics, obviously, the PS time to be intensive
Yeah, so the question was about antiemetics and tolerance. So it's funny, like we all say tigecycline makes you vomit. If you say to the CF patients, they say imipenem's the worst drug. And certainly, even though the hollow fibre model, they say tigecycline and imipenem are synergistic, but they're also synergistic against that part of your brain that makes you vomit a lot. And so, if you look at the guidelines for imipenem, they suggest a gram BD. But if you look at the product insert and what we know about time of MIC, we really should be giving, QID imipenem if we're going to give it, if we can. But again, most people tolerate that quite poorly. So I certainly would routinely give antiemetics as a pre-dose for those drugs. Yeah. But some people like that 72-year-old Kyle, he's had no nausea at all. So, yeah. My last question.
So for the patients that you've given rifabutin to, have you asked the laboratories to perform susceptibility testing? And if so, has that information been useful?
Yeah, so we can't do rifabutin susceptibility testing to my knowledge, Chris.
We can do it on a commercial count.
Yeah. So we haven't been able to do that.
Okay, we might move on there. Thanks, Andrew. Right, I'll invite Rachel back up to talk to us about clinical trials ongoing in NTM.
Okay, so Andrew's set the stage well for the difficulties with M. abscessus. But we'll talk about a few trials that are out there. If you go to the clinicaltrials.gov website, there's actually 73 trials or studies listed for NTM, which is fantastic news because when I started in this there was 0. And because the disease is becoming more common and it's difficult, people are interested. There's 3 studies there, which I won't talk any more about other than to just make you aware that they've happened, that have been completed, but we haven't seen any published results. One was looking at interleukin-12 in both disseminated and severe pulmonary disease that was done at the NIH. There was the study of rifabutin that was completed in Texas years ago, but I haven't seen it specifically published as such. And then there's this subcutaneous interferon gamma study that was also completed, now 20 years ago, but nothing's been published, so we assume that it was a negative study. There was a study on inhaled interferon gamma that failed, but there were some methodological issues associated with that study where it was given to cavitary patients on 3 times a week suboptimal companion regimens, and that was stopped early. There are some more studies that are ongoing, and the first of those is liposomal amikacin for treatment of abscessus, and that had some preliminary results published last year at the ATS. There's a recombinant IL-7 study for refractory disease that's being done in in St. Louis. A comparison of 2 versus 3 antibiotics. That's a multi-centre US study that's comparing azithromycin ethambutol to the 3-drug combination with rifampicin in non-cavitary disease patients. And there has been some preliminary data from Asia that suggests that the 2-drug regimen may well be sufficient in some patients. And then the French group are doing a clarithromycin versus azithromycin study, and that's a difficult one to do because to get numbers to show a difference between those 2 drugs in a multi-drug regimen, they'll need about 400 patients, and so that's been ongoing for quite a while. So the most successful study that we've seen recently, and it was successful in a number of ways, not only was the drug successful, but it was also successful to demonstrate to the world that these trials can be done. They're very expensive, that you need a lot of sites to recruit, and they run over a long period of time because this disease takes a long treatment course. But the first of these was the 112, the amikacin, liposomal amikacin for inhalation. The 112 study was an open label study, and that included CF, non-CF, abscessus and MAC. And based on the results, the promising results from that study, they then went on to do the 212 and 312, which have now both been completed. So the 212 study was a prospective multinational randomised study. It was open label, so the placebo group didn't get a sham nebulizer. But it was looking at amikacin liposomal inhalation solution, which has now been called ALICE, administered once a day when added to guideline-based therapy, GBT, for patients who had refractory MAC lung disease. So they had to have failed standard therapy. They were randomised 2-to-1 to either ALICE plus GBT or continued GBT alone. And the primary endpoint was the percentage of patients who had achieved sputum culture conversion by month 6. And that was defined as 3 consecutive months of negative cultures, which is really a big ask in a refractory patient. And patients went into this study having been on 12 months therapy up to 8 years, 10 years of therapy and be failing. And to ask them to add a single drug and expect that within 3 months they would convert their sputum and stay negative was a big ask. But nevertheless, they were able to demonstrate it worked. So any of the patients, all the patients who achieved that culture conversion by month 6 then stayed on the drug for to achieve 12 months culture negative. So this is the nebulizer headset and the device, which is really quite a small nebulizer kit. So patients were screened and randomised 2-to-1 to ALICE and GBT. Here's your 6-month primary endpoint, percentage of culture negative patients at this point, and those that were culture positive still on the GBT arm then had the option, and those that were, anyone who was still culture positive at 6 months then had the option to go over to the 312 study or to stay on the observation and be observed for the rest of this 12-month end of study. So there were 336 patients randomised with refractory MAC. This is the conversion rates at the different months. So this is between, there was actually a baseline rate of conversion that occurred between screening and month 1, which is, you know, what happens when you put people on clinical trials and pay them a lot of attention. And then by month 2, 3 and 4, we see 29% of patients by month 4 had converted their sputum to negative. 8.9% who stayed on the GBT converted to negative. Those who converted did improve their 6-minute walk distance, which is a surrogate for improved activity levels and quality of life. And the patients who had the ALICE converted quicker than the patients who stayed on GBT. That's been published, and those results were then used to get the drug approved by the FDA, and it's now available in the US. The durability of that response, so if you look at those patients who converted and then sustained that conversion, those results, I don't think they've actually been published yet, but this is the durability of the 65 patients who converted. If you then look out to the 12 months end of study, 62 of those stayed converted, whereas 70% of the 10 people, 7 out of the 10 who converted on GBT, 3 of those relapsed or reinfected, or actually relapsed when you look at their PFGE profiles. Adverse events were not insignificant in this study, and most of them were respiratory in nature. So it does, if you've ever used the intravenous formulation of amikacin, it does cause quite a lot of upper airway irritation, and one of the attractions of putting it in the liposomes was to try and reduce the upper airway exposure so that you had less free drug, more was encapsulated in the liposomes and released in the lower airway. And whilst there's not been any comparative liposomal versus IV studies, it would seem that the liposomal did have less rates, but if you have a look here, there was still significant numbers of 47% of patients had some degree of dysphonia. There was a small percentage in whom that was quite severe, and they had to either stop the drug and restart in an intermittent fashion to try and get used to it, and that does seem to help. Patients tended to cough more, which was actually a good thing for a lot of these Lady Windermere patients because they don't cough very effectively, and a lot of them struggle to get sputum samples. But many of the patients we put on the study who couldn't cough much before, they coughed on the study, we managed to get samples, and it actually helped with pulmonary clearance. Bronchospasm, we didn't see any bronchospasm, but it was reported in the trial, and there were some cases of hemoptysis, but not significantly different to the GBT. If we, there were certainly some serious adverse events, but not anything significantly greater than the background regimen. Hearing loss was not significantly different. In fact, the GBT group had more hearing loss than the amikacin group, but tinnitus was. So 7.6% of patients experienced tinnitus, and a lot of those patients it resolved after the treatment was stopped. And then this dizziness as a sort of surrogate for vestibular dysfunction. It's a little bit soft, but that was also reported. And most of the adverse effects in the ALICE group occurred in the first 1 to 2 months, not later on. There was not really much that occurred later. And if you could nurse those patients through those adverse effects at the beginning, because most of them were local and a lot of them did resolve or improve with time, then the patients did all right. So if you were on the 212 study and you got to month 6 and you were only on guideline-based therapy and you were still culture positive, you had the option to then receive the drug through the 312 trial. So those patients could roll into the 312 trial here as the ALICE naive group. Those that were on ALICE and guideline-based therapy who hadn't converted at 6 months, and you had to wait till 8 months to get those results, so they'd effectively had 8 months of ALICE, they could then go into the 312 study and continue on the drug. So every child got a prize in this trial. You know, no one got placebo forever. So these patients then went on and got 12 months of ongoing ALICE, and then there was an off-treatment phase there. And in this 312 study, and I don't think these patients have been, this has been published yet, but the manuscript's pretty much ready. There are 163 patients that were enrolled. 73 had prior ALICE, and the rest, I don't know what happened to that box, but the rest were ALICE naive. 33% withdrew. This withdrawn by patient, I'm not sure why they were, but not too many were because of adverse effects. 67% completed, roughly the same between the two groups. And they basically were then able to reproduce the same findings. So if you look at the ALICE naive cohort, by month 10, 33% of those had converted their sputum. If they'd had prior ALICE, another 13% had converted their sputum by month 10. So still similar and consistent effects of adding ALICE into a failing regimen. Then looked at the results according to baseline clarithromycin susceptibility. We know that macrolide resistance significantly affects the outcomes for MAC disease. And here you can see this is the purple bar is the 312 study, 37% converted if they were susceptible or had an MIC less than 8. This is the 312, very similar. This is the guideline-based therapy alone. And the same here if you've got intermediate clarithromycin susceptibility, similar sort of results. But if you've got macrolide resistance, clearly the results are worse, but not as bad as GBT alone. So there is a role for this drug, particularly if you have macrolide resistance. If you then look at the amikacin MICs, and this study and the previous ones were actually quite useful to demonstrate whether the cut-offs for amikacin susceptibility were useful clinically. And this is where, and I think, Chris, correct me if I'm wrong, but I think that the next CLSI guidelines will actually have 128 as a cutoff for amikacin. So if your MIC is 128 or higher, then you're considered to be amikacin resistant. You can see if the MIC was greater than 64, then no one converted in both groups, and that was the same for the preceding 212 study. But if your MIC was 24, the green bars here are the converters in both studies, and the purple are the non-converters. So the baseline amikacin MIC did seem to be useful. So there are, that drug is now approved, and in the US it's $380 a day, which amounts to about $135,000 a year for a 12-month course. It's not expected to be that price when it eventually comes to Australia, but the company have been very generous in providing this drug on a compassionate use basis. The paperwork's relatively minimal, and between us in Brisbane we've probably got about 15 patients on compassionate use access to the drug. And you just need to email the compassionate use email line with the form, and the company send it out, provide it free of charge. So there are a few extra trials that the company are planning for the next 12 months, and they're currently selecting sites for these. They're looking at an add-on therapy in abscessus disease, trying to incorporate it as part of the 3-drug regimen for treatment-naive MAC, as a substitute for rifampicin, and they're going to do a paediatric study which will mimic the converse study so that they can then look to get approval in children. So moving away from amikacin, what else is out there? So there's been a lot of interest in nitric oxide, which is a naturally produced molecule that plays quite a significant role in our host innate immunity to a variety of organisms. There's been interest particularly in the CF population because CF airways are deficient in nitric oxide. It does have broad antibiotic or antibacterial activity. There was a first study that was done and presented was done in Israel with 9 cystic fibrosis patients, and that's been presented and published. These studies are all on the clinicaltrials.gov website. So there's a proof of concept study in Oregon and 2 studies in Vancouver that are ongoing in this. This is the study that was published from Israel, and they looked at quite young patients with cystic fibrosis, so over the age of 6. They had 9 abscessus patients. They were admitted to hospital, and you had to, because of the duration of activity and the issue with methemoglobinemia that can occur with prolonged nitric oxide use, they had 5 30-minute treatments a day at 160 parts per million of nitric oxide. So they were kept in hospital for 2 weeks and given this fairly intensive treatment. You can imagine with the fears of transmission that these patients were isolated for 2 weeks and given this fairly hefty stuff. And you can imagine keeping a child in a single room to do it would be quite challenging. This was then reduced to 3 treatments a day out to 3 weeks, and then they had follow-up. They looked at 6-minute walk distance, safety and bacterial load. This is the safety data, and they showed there were very few side effects and it was very well tolerated. The 6-minute walk distance seemed to increase while they were on the treatment as over the 3-week period. After they stopped treatment, it dropped off a bit. The FEV1 in this CF population increased while they were on the therapy, and it dropped off after therapy was stopped. The time to positive culture also seemed to increase through therapy, less of a drop-off after therapy. The bacterial load did seem to increase and then decrease. And interestingly, they also looked at Pseudomonas load, and that decreased significantly as well. They've then looked in vitro at how this may work in combination with antibiotics, and they've looked at synergy between nitric oxide, amikacin and clofazimine with higher doses of nitric oxide, and there does seem to be some synergism here. These bars here are amikacin alone, amikacin with nitric oxide at different strengths, different concentrations of nitric oxide, and these are all different strains of abscessus, and you can see that the effect is greater with some strains than with others. And then similarly, they've shown down here the same sort of thing with clofazimine, that there is synergy, but the variability amongst the strains does suggest that you may need different durations of treatment. This is the device that the company has developed that will deliver the nitric oxide. It's a little bit like a CPAP machine, and they are currently negotiating trials, and we will be a site here in Australia. We'll have a site in Brisbane to do this. It's going to require a 5-day confinement initially for 4 times a day treatment that will continue for a couple of weeks, and then it will reduce down to a twice a day treatment after that. So there's also been a lot of interest in immunotherapy, and you can see by the first slide there were a few studies looking at IL-12 and interferon gamma, because really it's felt that these organisms are of low virulence and they do require some sort of host abnormality, and so if we can augment the host response, surely we can get better clearance of these organisms, but that hasn't really yet borne out in any of the trials. The most recent one that's just finished is a trial of inhaled GM-CSF. This drug was developed primarily for pulmonary alveolar proteinosis, which is a condition where you get anti-GM-CSF antibodies, and then it progresses to ARDS. And there has been some utility in some studies that have shown that may be beneficial in that. But because it has the ability to mobilise different white cells and macrophages in the lung, then it has sort of been appealing in something like mycobacterial disease where macrophages play a role. But also surfactant homeostasis is important, and the GM-CSF can affect that as well. And there's some in vitro, an animal model stuff that suggests this would be useful. So we participated in a pilot trial, which was an open-label 48-week therapy for patients. Started out as 24-week therapy, and then based on the results at 24 weeks, it was extended out to 48 weeks. And it was a similar criteria to the ALICE trials, refractory patients, failing therapy, but we tried to include both abscessus and MAC patients. In December of 2018, the results on the 14 subjects that had completed treatment at that stage showed that 4 out of 10 had a consistent smear conversion to negative, 3 had negative cultures that were maintained out to 20 weeks, but no response really in the abscessus group at that point. And the safety data looked pretty good, and so the study was extended out to 48 weeks, and it's just finished, and the data is currently being analysed, and we should have some results of that within the next 6 months or so. That study is then being done, the same study is being done in CF patients through the National Jewish in Denver, and the recruitment for that is ongoing, so watch this space. Clofazimine has been recommended as an add-on therapy for people failing treatment for MAC disease. We use it a fair bit here because we can get it. The Americans don't use it much because it's a nightmare of paperwork for them, but the Canadians use it a lot. And this study came out of Canada that showed that patients who had culture conversion, overall they had a culture conversion rate of MAC patients of 95%, 49% relapsed, and then 36% were retreated. If you had clofazimine as your third drug instead of rifampicin, 100% had culture conversion compared to 71% who received rifampicin. Now the numbers are a little skewed there, but still it's very well tolerated. It seems to be, in our experience, better tolerated than rifampicin. It also has some synergism in vitro with amikacin for both MAC and abscessus, so it's quite appealing. So the group in Oregon are leading this national study in the US. It's actually a monotherapy study. So in patients with nodular bronchiectasis, mild disease that you don't feel have to be treated straight away with a triple drug regimen, so you certainly wouldn't put a cavitary patient in here, they're getting 6 months of clofazimine monotherapy versus placebo to see what effect it has on its own. At the moment, they've got 102 patients enrolled, and it'll be interesting to see what those results show. Andrew referred to linezolid and tedezolid, and both of these have been touted as drugs useful for mycobacteria. There's been some work done on their MICs against MAC and abscessus, but there have been no trials published. There's been maybe one case series that a very small number of patients, but there's really been little data, and there doesn't seem to be much interest from the company in doing NTM-type trials. And part of the issue with those drugs is the duration of therapy and the limiting side effects that mean that you can't really use it for that long. There has been one study of bedaquiline that's been published, and this comes from the Texas group, and they basically just reported on the patients whose insurance company would pay for bedaquiline. So these were refractory patients. If the insurance company would pay for it, they put them in a database and monitored to see how they went. In 2018, Julie presented the results of 9 patients. There was some activity there, but it was nothing startling. They seemed to improve in their symptoms. Some converted. There wasn't any significant QT prolongation in this cohort of patients, which was interesting. And again, another drug that causes nausea. So just to get on to probably the most promising trial that's coming is, in terms of Mycobacterium abscessus, is the FORMAT study. And this is a really huge undertaking that Claire Wainwright is driving in Brisbane. Claire's a paediatric professor of respiratory medicine at the Queensland Children's Hospital. And on the back of our NHMRC-funded national study of NTM and CF, where we're looking at prevalence and epidemiology of NTM in the 21 CF centres across the country, we're then offering an opportunity for those patients identified through that study to then go into a treatment trial. And this is basically to find the best combination of drugs for the treatment of Mycobacterium abscessus. And we were successful in getting funding through an MRFF grant to do this within Australia, and then we've secured another $2 million US from the Cystic Fibrosis Foundation to extend it internationally. It's a huge study. There is a big team of clinicians involved from several countries, but we're also looking at a number of sub-studies within this treatment trial, looking at roles for microbiology, serology, pharmacology. Andrew and Jason are going to be doing the PK/PD aspects of all these drugs. It's a huge statistical undertaking because it's a platform adaptive trial, which the statistics of which blow my mind. We're also looking at health economics. Harm Tiddens in the Netherlands is going to be looking at all the CT scans and the value of CT scoring. We're looking at gene expression signatures, immune responses, T-cell function, mitochondrial stress and macrophage function, and heaps of things. These patients will be dissected pretty well. So anyone with abscessus pulmonary disease can go into this study. There is the option for a period of observation. They don't have to be treated straight away. We're aiming to enrol 300 patients, 150 with CF and 150 without CF, and we're going to establish the best therapy against international guidelines. And once we establish the best control group, we can then bring in novel therapies to the regimens to assess them against current therapies without having to do one study comparing two things, stop, do another study and compare two different things. This study happens on the run. And if you have a combination that's either got unacceptable toxicity or it's performing badly, with frequent statistical analyses along the way, you can drop a regimen or change a regimen so that you can improve it and then ultimately get, at the end, your best combination, and the trial can essentially go on forever. So you've seen this slide before. This is the current standard of care amongst the CF units with the initiation phase of intensive therapy. You'll note that clofazimine is not part of this intensive therapy as in the recommended guidelines, and there's been a bit of discussion as to why not. And the author of these, two authors of these documents said, well, they left it out because in the interests of drug load and pill burden rather than any scientific evidence. And when clofazimine and amikacin have demonstrated synergy, it would make sense to have the clofazimine going while the amikacin's going. Nevertheless, that's what the guideline is, and so this will be basically the control arm of the format study. The comparative arms will have inhaled amikacin in the initiation phase here instead of intravenous amikacin, and then another arm will have clofazimine included in the initiation phase at the beginning to see whether there's any benefit there. We will examine whether you need, what the different duration of intensive phase does. So is 6 weeks better than 12 weeks, or is 12 weeks better than 6 weeks? Depends on whether you look at efficacy or toxicity. In patients who have persistent cultures here at 4 weeks. And then with the consolidation arm, we're going to add inhaled amikacin to the oral therapy and see whether that plays a role. Probably should show this slide first. So these are the arms of the study. So if you can enrol in the study and you can go into the observational cohort if the treating physician feels that treatment's not indicated just yet. But at any time along here in the observational cohort, the clinician feels that treatment's indicated, well, they can go into one of these arms. And that will also give us an idea of the proportion of patients that do actually progress and that do need to go on to therapy. Because there's a bit of debate. There seems to be a lot of CF physicians who think first isolation abscessus, bang, we've got to treat this is bad, let's get rid of it. Whereas Andrew showed nicely aside that at least a third of those patients don't have another ISIL ever again, and potentially we're treating these people with toxic drugs unnecessarily. Another third of them don't need treatment based on a single centre, but this will give us much more information about that. So then you have your different intensive arms and your control arm. At 4 weeks, they'll have a sputum sample done. If they can't produce sputum, it'll be a bronchoscopy. If in the 2 weeks while we're waiting for that culture to come back, they will continue on intensive phase, so they'll have 6 weeks of intensive therapy. If they're still culture positive, at that point, they can then be randomised to more intensive therapy or to go into a consolidation arm, which can be A or B. and then we can have new drugs that come in and form these future consolidation arms and future intensive arms, and the analyses goes on, and the substitutions go on and on, so ultimately at the end you come up with the best combination and least toxic combination. Currently we've got 26 sites signed up in Australia, 2 in New Zealand, there's about 40 sites in France, 2 in Sweden and the Netherlands, a couple of others in Europe. The UK are currently seeking funding to try and come on board as well, and then we've got 2 sites in Canada. So there are others, as I mentioned, there's a number of secondary objectives here to optimise the therapeutic drug monitoring, and Andrew and Jason are doing some fabulous work looking at not only what the levels mean, but ways of sampling, so looking at children and different ways such as saliva and dried blood spot, and some novel ways of monitoring for children. We're looking at biomarkers of disease activity. Can we find something better than a sputum and a CT scan that tell us that a disease is going to progress? Are there other gene expression signatures, serology, other tests that we can use that will predict who's going to do badly and should be treated intensively, and who's going to be okay to watch and clear spontaneously? And so there's a number of other quality of life and cost effectiveness analyses along the way. So just to wrap up, the studies that are available to people in Australia, we will have a couple of sites in Brisbane that will be participating in the new ALICE studies. Particularly the treatment-naive MAC patients, that's an option for them. Treatment-naive abscessus patients, I'd encourage everyone to try and get your patient, if you've got an abscessus patient, try and get them into the format study, not only to give them a good option of getting the best treatment, but also to inform us on how to best manage these patients. It's an uncommon infection, and to get information we need big numbers, and we need everyone to be involved. If they've got pre-treated abscesses, so to go into format, if you've had treatment within the preceding 12 months, you're not eligible to go into format, but those patients may be able to go into an ALICE study. And if you've got refractory abscessus or MAC patients, then the nitric oxide study is certainly an option. And at the moment, we're looking at, because the intensive inpatient treatment part of that nitric oxide study is a challenge, we're looking at the possibility of having one centre in Brisbane that will do the confinement, but then the patients can go back to other centres to do the outpatient part of it. So if you can't do the confinement part, we can do it for you. And that's it.
Thanks, Rachel. Any burning questions before we break for morning tea? Okay, well, we might break for morning tea. See you back here in 20 minutes. Morning tea's just out through these doors, and feel free to go outside and get some fresh air thereafter.
Thank you.